Thank you all for joining us today as we fight for meaningful pharmacy benefit manager reforms that will lower drug costs for patients, employers, and taxpayers. I'm James Gelfand. I'm the president and CEO of the ERISA Industry Committee, representing employer sponsors of health benefit plans. For years, many of you and your bosses have worked to rein in PBMs and to curb their worst practices. And we know this is a bipartisan effort with support of patients, independent pharmacists, employers, state and local governments, and many others, including forward-thinking PBMs and insurance companies. Unfortunately, the PBM legislation originally included in the 2024 end-of-year government funding package, which had been agreed to between Republicans and Democrats in the House and the Senate, ultimately was not included in the final bill. So now is the time for action. These key PBM reforms, including transparency, delinking PBM profits from prices, requiring rebates to go to employers and patients, and fair pharmacy reimbursement, they must be included in the March government funding bill. We're grateful to be joined today by a strong list of speakers, and it is my honor to introduce our legislative champions. I know that at some point during the briefing today, we're expecting to be joined by Chairman Buddy Carter. Representative Debbie Dingell is here with us, Representative Jake Auchincloss, and I believe Chairman James Comer also is expected to join us. So why don't we start with Representative Dingell.
Well, good afternoon, everybody. I left Buddy and Mark up where I'm planning on going. He said he's a pharmacist and he's leading the way, but he always says, I think you're crazier than I am on this issue. I'm here to say one thing: finish the job. For too long, pharmacy benefit managers have been allowed to operate unchecked. And unless you're paying attention, people don't even understand what that is doing to people. I hear from people back home and across the country, especially seniors, who can't conveniently access their prescriptions that they need to, and the exploitative PBM practices complicating the access to local pharmacies that they depend on and where they get to know people and they know the pharmacist. Independent pharmacies are often an invaluable resource in underserved communities, and we got to make sure they're staying open and they're competitive. But what drives me crazy is I ask questions. You know, PBM people don't like you to ask questions. But our pharmacies are we're being charged outrageous amounts of money. They're not allowed to tell us, but you ask the questions and you get answers. That the amount of money that we are being charged for through our insurance and what our co-pays is, it can be 2 to 3 to 4 or 5 times higher than what if you just can convince them to give you the prescription and not put it on insurance and what you just pay for. I mean, that's what people do not understand. That how much, and they're not supposed to tell you. They could lose their relationship. They could lose being a pharmacy that's reimbursed if they tell you the truth. And it ranges from little pills to big pills, and it's really outrageous. Last year, we reached a bipartisan agreement to implement common sense reforms to the PBM industry that would have put a stop to some of these tactics that distort prices. That's what I'm talking to you about, distorting prices, harming pharmacies. And who gets the benefit? Who gets the profits? The pharmacy benefit managers get the profits at the expense of the patients. Patients pay more. They don't even pay what the price is so that those pharmacy benefit managers can get rich. Well, I don't think they should get rich. I think people should be able to afford their medicine, period. Our agreement fell apart at the last minute. And I'm going to tell you, it really fell apart because I'm glad Buddy's not in here. I can say because a certain billionaire didn't like it. And I say it's time to finish the job now. We got to continue the fight to strengthen the PBM accountability and ensure Americans can get their medications at a price they can afford in a transparent way, closer to home, and at pharmacies that they trust. I've heard from many of my constituents that the harmful, aggressive tactics of the PBMs is getting worse. And actually, I can't tell too much of this because then they'll go find my pharmacist. So I'm not going to tell you, but the pharmacists are really sitting down and showing me what's happening. It's time to lower patient costs. It's not a partisan issue because you can tell the bipartisan feelings we have here. We already know we can come together on this, agree to this. Look at who's in the room today. It's just now to get this, it's time to get it across the finish line. So help be the voices that raise up the stories and tell people our patients deserve better. Thank you.
Thank you so much, Representative, and thank you for your critical leadership on this issue. So many of us have each experienced in some way the challenges that PBMs have created, increasing drug costs and threatening competitive markets. Today, we have several leading advocates to share their perspectives. What we'll do is, as the members come in, we'll interrupt, but otherwise we'll start our speaker lineup. And first up, I have Ohio Attorney General Dave Yost.
Some of you are probably aware that I began investigating the cost impacts to drug procurement when I was auditor of state in Ohio, an elected position, and we uncovered spread pricing in our original audits. When I became Attorney General of Ohio, we used litigation to go after some of these losses that the state was experiencing. And we are currently in court alleging anti-competitive activity by them, antitrust. The cases are stalled, and the reason I came down here today is I am now convinced that litigation is not going to reform this system. We're going to keep fighting. Don't get me wrong. We're going to push this with all of our might and try to get to a judgment. But what we've seen over and over again is that the PBMs just change the definitions. They just change the way they move the shells and the shell game around. That's why we need legislation. We need congressional action to fix this because at the beginning of the day, Congress created this problem. Let me explain to you how. The pharmacy benefit managers gain control of the formularies for the payers. Who gets paid, how much, on what tier, how easily, and how quickly. The way they make their money is they also have an exception to the federal anti-kickback statute. Now, if you're buying tires, I'm a salesperson. I come in and if I were to say, I'll give you this price and you buy them at this price and you kick back to me X dollars, I would go to prison for that. That's against the law. So the pharmacy benefit managers actually go out and do exactly that with the drug companies and say, except they're called rebates. Why do they get away with this? Why is it okay in healthcare? Because in the Affordable Care Act, there is a quote-unquote safe harbor that allows them to get these kickbacks from the drug companies, and that, in essence, is their revenue stream for their profits. That exception in the law is what creates this monster. In another context, you might well call it the VIG, and it needs to be fixed by Congress. Litigation isn't going to get this done, and I fully support the move to try to get this fixed through legislation, and wouldn't mind if we even went a little bit further. But we've got to cut that Gordian knot, and this legislation is an excellent step in that direction.
Hi, I may not be as famous as Attorney General Yost, so I'll tell you who I am. I'm Dr. Madeline Feldman. I'm a rheumatologist in private practice in New Orleans for 30 years. I'm also Vice President of Advocacy and Government Affairs for the Coalition of State Rheumatology Organizations. And I can tell you, I became interested in PBMs. You know, as a physician, I didn't want to hear another acronym, and particularly if it had to do with insurance. I was too busy trying to take care of my patients. But when I started noticing that my patients were being whipsawed, literally whipsawed back and forth from one drug to another, and it wasn't always in fact, most of the time it was to a higher priced drug, I started looking into this. And people don't quite understand, when I've testified before legislatures on various utilization management tools, and I talk about competition raising prices, I've had a legislator say, no, competition always lowers prices. We need more competition, and that'll bring down drug prices. Think of it this way. When you're selling your house, what happens the more people bidding on your house? Price goes up, right? And that's the same thing with the manufacturers bidding to get on the formulary, because they're not bidding on the lowest price. As Attorney General Yost said, they're bidding on the highest kickback. I used to say, I write a lot of articles about it, and I used to feel funny calling them kickbacks. But my son, who's an attorney, said, Mom, they wouldn't need the safe harbor from the anti-kickback statute if they weren't kickbacks, which is true. So let's call them kickbacks. And those kickbacks, for the most part, are a percentage of the list price of the drug. And the only person who is vulnerable to the list price of the drug are my patients. They pay their cost share on the list price. God forbid the PBMs would give them back a portion of the rebate and fees. They've reclassified a lot of those rebates now as fees. So rebate transparency can't get to them, which is why it's important that the fees are a flat market rate fee, not a percentage of the list price of the drug. My patients, from being whipsawed from one drug that they're stable on to a more expensive drug because it makes more money for the PBM, loss of control of rheumatoid arthritis. And I don't know if you or know anyone that has an inflammatory arthritis, which is a systemic disease. When they lose control, steroids come in, now we have infections, now we have diabetes, now we have hypertension. The healthcare cost to the patient and to the system is greater when patients lose control. And I would submit that patients are not being treated correctly, because let's face it, if an expensive drug is not on the formulary, nobody's going to take it. I don't have anyone, most patients at $100 don't even go pick up the drug if they know it's going to be $100 every month. So when we have $2,000, $3,000, $4,000 cost shares a month, that's when we start seeing healthcare going into the, into the mud, so to speak. So yes, transparency is important, rebate pass-through is important, but I think delinking the profits of the PBM from the list price of the drug will go a long ways to helping our drug pricing crisis and improve healthcare in the United States. Thank you.
Sorry, Joe. We're going to jump in right now for Representative Auchincloss.
Thank you. I apologize for having to be so brief and brusque. We're doing a markup in Energy and Commerce right now on a number of contentious topics, and Republicans and Democrats right now on healthcare don't agree on a whole lot, but my goodness, PBM reform needs to be one of them. And we have 3 steps ahead of us, all of which can be bipartisan, to take out the price gouging, the rent seeking, and the abusive malfeasant behavior that has come to define the big 3 PBMs in American healthcare, which dominate 80% of the market, which are driving independent pharmacies out of business, which are costing taxpayers billions of dollars every year, and which are raising co-pays for patients at the pharmacy counter. The first step is, let's pass the PBM reform bill that we had last Congress, 12 hours away from voting on that thing with a supermajority in Congress. Speaker Johnson, he flinched. The health insurance lobby flexed, and he flinched, and we can't let him do it again. Bring it up to the House floor for a vote. It will pass. Push it to the Senate. It will pass. We can save taxpayers $5 billion. We can ban linking of rebates to prices in Part D. We can ban spread pricing in Medicaid. We can insist on the transparency that will reveal further of their abusive practices. And we can mandate NADAC reporting so that we have more of a cost-based, transparent pricing mechanism for our independent pharmacists. It's a darn good bill. It's not everything we need, but it's a darn good start. And let's get this thing passed this year. Step 2 is we've got to go after the new money-making engines of the PBM cartel. And they're very clever. I know that you've all been very worried. How are they going to make money if we do pass this law? Are they going to be okay? Yes, don't you worry. The Express Scripts CEO and Optum CEO are hard at work figuring out new ways to gamify healthcare to their benefit. And the two biggest drivers are fees from the group purchasing organizations based in Ireland and Switzerland. And the second is specialty steering. The GPOs are a complete rat's nest where even Congress doesn't have sufficient insight into what's happening over there. One thing I know, though, is that there aren't a whole lot of ERISA, Part D beneficiaries in Ireland or Switzerland. So the fact that they're sending these PBMs for PBMs all the way across the ocean tells us that they're trying to avoid regulatory oversight, and they're trying to play tax games, and they're trying to collude. The fees coming out of these GPOs are growing, and it's their way of trying to avoid and get ahead of congressional and state oversight. We can't let them. We got to stay one step ahead of them on GPOs. And then number two is the specialty steering. They take these generic drugs, they label it with a business, not a clinical, a business designation of specialty. They steer it to affiliated pharmacies, and they price gouge 10,000, 20,000, 30,000% for drugs like necessary for leukemia or multiple sclerosis, for HIV. And it's their biggest moneymaker. Again, don't believe me, listen to their earnings calls with Wall Street. They will tell you specialty steering is the future for us, and you can see it in the charts for their revenue streams. Congress has to hit hard on that. I've got legislation to do it. And finally, step three is we got to break them up. No PBM should be able to own pharmacies. We've got bipartisan bicameral legislation, the Patients Before Monopolies Act, the PBM Act, that will undo some of the damage that was done in the last 25 years of relentless consolidation that has corporatized healthcare and has empowered the middlemen at the expense of providers and patients. These are the goals. The first step, though, is let's pass the bill we already had drafted and vetted and ready to be approved in Congress. Please put your voices to work telling Speaker Johnson to bring this bill up. Thank you.
My name is Joe Shields. I'm the founder and CEO of an organization called TransparencyRx. We're a coalition of leading transparent PBMs. So despite all the things that have been said about PBMs, there are some hopefully good guy PBMs, good person PBMs out there that are doing meaningful work. To give you a distinction between the work that we do versus spread pricing, vertically integrated PBMs, where they rely on sort of manipulation of price, our approach is what's been described here, a flat fee that's essentially the major source of revenue of our members. We're at 10 companies plus across the country. If we were a PBM, we'd be the fourth largest PBM in the country. It's really a question of scale and competition. And one of the biggest barriers of competition that are out there is one of the points that's already been made. It's these GPOs, what I'll call so-called GPOs, group purchasing organizations, rebate aggregation, and give a sort of historical context. The only reason the GPOs were created is because President Trump in his first term wanted a rebate rule in place. And magically, the three largest vertically integrated PBMs and their health insurers said, well, wait a second. We're going to lose our safe harbor provision under the traditional PBM model. We need to find a different model to create so that we can continue to manipulate and inflate the market with harmful pricing. And that's what occurred. They shipped the drug costs and the data associated with that. You know, in terms of indications, if everything that we've seen from United Healthcare as an example in terms of their own data security and trustworthiness around data that came out of the inquiries into Change Healthcare should ring an alarm bell for all of us about what's occurring around the GPOs, much less the cost of that. And you don't need much evidence as to the malfeasance of PBMs. Just look at the recent FTC inquiry and look what's occurring around generics. There's no other explanation to the inflation of generics other than the work of traditional PBMs, of spread pricing PBMs. And just to inoculate everybody in the room, we can already predict what's going to be said in response to this press conference and this event today. Their spokespeople and mouthpieces are going to say things like, well, if you do this type of reform, you're going to see premiums go up. Well, premiums are already going up. They defended their model on the basis of two assumptions. One, that you would see better access to drugs and greater affordability, that healthcare outcomes would improve. The United States of America right now is behind the country of Latvia on healthcare outcomes. So just take that into consideration. Drug pricing is continuing to go up. The relationship, and there's a USC Schaefer study that shows this, between rebates and the price of generic drugs. For every dollar spent on rebates, generic drugs go up by or $1.13. So they're positively correlated. Just mull on that. Mull on the positive correlation between rebates versus transparency. You compare a transparent model, you can look at a Johns Hopkins study which shows waste-free PBMs, transparent PBMs, save anywhere from 8 to 12% in terms of commercial savings. So that's why the changes I think that we're talking about here have to be comprehensive. And I would just echo everything that's been said, not only tackling the challenges and complexities of Medicare Part D and Medicaid, but assuring that there's meaningful commercial reform. There was a lot in that December package that should be law at this point. And we're hopeful that's the starting point for meaningful action, not only in the coming weeks, but in the years ahead. So we thank you for your interest and ongoing support, and we look forward to working with all of you. Thank you again.
Good afternoon. I'm certainly not an expert. The experts are here beside me. I represent the National Grange. It's a 157-year-old rural grassroots membership organization that has two buckets of purpose in its mission, and that's community service and issue advocacy. What we've been hearing increasingly in recent years is, why is health care so expensive today? And maybe even worse than that, why do my drug prices keep going up? It's great to have these cutting-edge discoveries, but I have to pay so much for them now that I am not absolutely able to pay for them any longer. We had no idea what PBMs were. My background is agriculture. I did have a master's degree in physiology that at least lets me know how chemical reactions act in the body sometimes. But we're on the other end. We're on the receiving end. And what is a PBM? Well, you know, that's hard until you just really, really take the cover off. And it's really simple. You know, if this guy is going to help us buy things and he offers to sell me something at what I think is a pretty good price, he goes and buys it from a wholesaler that's so much cheaper than what he quoted me. He brings it and sells it to me at this price he quoted, and in between goes to him. I mean, that's just not very complicated. So how do you explain a PBM? Pharmacy Benefit Manager. You know, I don't know one, and I don't know anybody in my organization that knows one, but we do see the results. Big question is asked, why can't we do something about drug prices? Well, as we started investigating, yes, we can do this, we can do that, and we can do the other thing. The first biggest tranche we can make in drug pricing in everything we've looked at appears to be Pharmacy Benefit Manager reform. So we've kind of dubbed it Pharmacy Benefit Manager, kind of glosses people over a little bit. So we're calling it the pull back the mask exercise. If we'll do that, then we can get folks to understand what's going on between the manufacturer and the retail counter when the patient walks up to it. You know, PBMs are hurting our rural, small, independent pharmacies. You know, 1 in 3 have closed since 2010. We're finding the same thing in rural clinics and rural hospitals. About 14,500 zip codes have one pharmacy or more. That's not half the zip codes in the United States. So what that says is that over half of the zip codes in the United States does not have a pharmacy. Well, when you don't have a pharmacy, you don't get your prescription filled on time. The farther you drive, the less often you might go and fill it. That means you miss doses, you skip doses, and what does that do? It messes up your regime. We are appalled to hear of some of the I won't say profit-taking, some of the prices that we are hearing. We heard about one pharmacist in Oklahoma that looked over the insurance papers of one of his clients and found CVS charging $138,000 for a therapy, that he found a site online that could buy it from a wholesaler for around $14,000. With those kinds of figures, you can understand PBMs. And so, like I'm saying, we're grassroots, we're rural. We didn't think we were underserved, but perhaps we are, particularly in healthcare. And we do need to at least get started on drug pricing reform, and in everything we can see, it's Pharmacy Benefit Manager. So we're with you, and let us know what we can do to pull back that mask.
Good afternoon. Thank you for taking time to be with us today. We appreciate it. My name's Chris Kress. I'm with the National Association of Chain Drugstores. I really want to emphasize that the NACDS has been warning of the perils of pharmaceutical benefit manipulation for 15 years now. This is something that we have been preaching about, the fact that these PBMs are getting too big to play fair. Unfortunately, we have been proven right. The reason that I really want to emphasize that 15-year time frame is that we don't want there to be a perception that, oh, well, it didn't work out in the last Congress. We'll see if we can maybe get it done this Congress, and if not, maybe in the next one. This is an issue that it's not just that the time has come, the time is long overdue. Pharmacies and people that they serve, they are at the breaking point. Let's talk a little bit about the cost of inaction. The cost of inaction right now is dramatic. A lot has been said about the FTC most recent staff report that came out. That was passed unanimously, 5-0. Incredible result to get that report out. Think about the money involved here. We're talking about $7.3 billion in revenue from markups on not just any drugs, drugs to treat cancer, drugs to treat HIV. That is unfathomable. When you look at what the FTC found through its really, really robust investigation, you're talking about just from the time that the Congress took its last vote in December of 2024 to today, the findings that the FTC has suggest that we're talking about hundreds of millions of dollars that have been not driven out of the system just because Congress didn't act when it could have, and just because we're now into this Congress and we're still waiting for action. That needs to change, and I'm really counting on you to go back to your offices and really, really work with your colleagues to find ways to get this to get this done. This is the cost of inaction, and it really needs to end right now. I would emphasize, too, that the FTC has been a true leader in this, but it's not just the FTC. You look in this institution as well. The House Oversight Committee has done extraordinary work on a bipartisan basis, and I think that really, really needs to be emphasized. I'll take a direct quote from their report. They found that the PBMs inflate prescription drug costs and interfere with patient care for their own financial health. I mean, think about that. Why are they doing that? For their own financial health. Talk about the cost of inaction. You could talk about the money, but we also need to talk about healthcare access. And this is playing out in communities all across our nation. If you take a look at just the 2 years of the last Congress, the number of pharmacies that have closed just during that time frame is ridiculous. 1,300 pharmacies per year over the last Congress. 5,800 locations closing since 2018. That is 10% of all pharmacies. Now, those are big numbers. However, when you bring it down to the local level where your members of Congress are serving, the impact is tremendous. I had the opportunity to serve a member of Congress from rural Pennsylvania when I was a congressional staffer. And it was interesting to hear how families talked about rural health care. Yes, they talked about access to health care. Yes, they talked about staying healthy, but they talked about it in so many more deep levels even than that. It was if health care disappeared from their community, jobs went away, employers went away, and that meant that people's sons and daughters had to go seek employment elsewhere. You can make the case that lack of health care tears apart families, it tears apart economic viability. This needs to end by taking on the PBMs right now. We really appreciate the bipartisanship that's been brought to this. If you look at what the American people say, we have a poll conducted by Morning Consult that NACDS commissioned. 71% of voters say that this needs to be a priority this year. This needs to get done this year. I really appreciate the leadership of Attorney General Yost. The leadership's extraordinary, and he's not alone. Last year, 39 AGs said that Congress needed to act. People really find that persuasive, and they should. They know it. They know it at the state level, what the PBMs are doing to their states and to their communities. We were really close, as has been said, last December. We thought it was going to happen. This was a great, great package, okay? The solution is on the table. We can cite chapter and verse of exactly how that was put together. It was extremely well orchestrated. That bill, that package of PBM reforms, it needs to be enacted. The one final word I would say, it's been said, pharmaceutical benefit manipulation, yes, that's exactly what they're doing. They also manipulate the politics. Be on guard. You will talk with them. They're going to make the case about, as was said today, it's going to increase premiums. We've heard it all before. Don't let them go there. Hold their feet to the fire. Let's get this done now. I appreciate your time.
Thank you. I'm happy to now introduce Chairman James Comer.
Well, thank you very much. It's great to be back here to talk about the need, the necessity for PBM reform. I spoke last year and I talked about the beginning of our oversight investigation into the abuses of the PBMs, and I'm very pleased that we had 3 committee hearings and we published a report. I'm sure everyone here has read that report, but I would kind of like to summarize what our investigative committee turned up in a bipartisan manner. We found that obviously the PBMs are one of the largest drivers of the increased cost of prescription drugs, and that's totally against what they advertise themselves as being, totally counter to what they were created to do. We found they actually were one of the biggest price increasers. We found that PBMs dictate which drugs a patient can use and force patients to use mail order instead of competing pharmacies, even when the alternatives are cheaper. We found that PBMs under-reimburse competing pharmacies and do not pass those savings on to patients or payers like they advertise. We found that PBMs use abusive rebating practices, making it more difficult for generics, biosimilars, and competitors to gain market share. And we found that PBMs use their size and complexity to hide their actions and have recently begun creating business entities in the Cayman Islands, Ireland, and Switzerland to prevent oversight. These were the key findings of our investigation, and it was pretty brutal to the PBM. So this all may seem hopeless, but there is light at the end of the tunnel. PBM reform is coming. There's no doubt about that. President Trump has talked about how bad PBMs are and the fact that they're driving the cost of prescription drugs through the roof. President Trump and my good friend, Chairman Brett Guthrie, who I knew from college days back in Kentucky. I served in the Kentucky State Legislature with Brett. He's now the new chairman of the Energy and Commerce Committee, and I think he understands the need for PBM reform, and I think that he strongly supports PBM reform. So I'm very excited that there's a real opportunity for us to have lower cost, more Transparency Act signed into law this Congress. I can also say with certainty that the Oversight Committee's investigation is not done. Last Congress, obviously, we released a report detailing the many abuses of PBMs that are hurting independent pharmacies and driving the cost of prescription drugs. This Congress, we're going to continue our investigation. I hope that our findings will be able to get legislation, like my friend from Georgia, Buddy Carter's Pharmacists Fight Back Now Act, across the finish line. I'm certain there will be more legislation that my colleagues and I bring forward to address the ever-increasing cost of prescription drugs and once and for all put an end to the PBM abuses. So I really believe there's real opportunity this Congress, and I pledge to you all to work with my colleagues in a bipartisan manner to try to pass significant, meaningful PBM reform legislation. So thank you again for being here, and I appreciate the opportunity to say a few words. Look forward to working with you in the future. Thank you all.
Good afternoon. I'm Erin Callahan with the Diabetes Patient Advocacy Coalition. My colleagues and our congressional leaders have done a wonderful job explaining the problem and the things that we need to solve them. I'm here to share a bit about the impact to patients with you. I've been living with type 1 diabetes and on insulin for 38 years. 133 million Americans live with chronic conditions, and 38 million of us have diabetes, requiring daily, hourly, even to-the-minute management. Treatment and therapies range from chronic to acute and include lifestyle adjustments and prescription meds just to stay alive, let alone healthy. We are burdened by our own bodies betraying us and by players in our healthcare system that prioritize profits over patients. PBMs are responsible for taking away therapies that work and destabilizing our care, all to drive us to their preferred products and pricing schemes. These practices are driven by profit, artificially inflating list prices to increase rebates, and keeping their revenues and fees tied to those high prices disincentivizing patient access to lower-cost treatment options, and forcing us to make life-threatening decisions at the pharmacy counter. These high prices can lead to rationing and prescription abandonment and have devastating impact on patient outcomes. In light of this, last year, the FTC filed a lawsuit against the 3 largest PBMs and their affiliated group purchasing organizations for engaging in anti-competitive and unfair rebating practices, underscoring the need for PBM reforms. But we need to finish the job. We are grateful for the intention that these dangerous practices are finally being given, and we stand here today in support of this bipartisan congressional effort. People like me live in a system that reminds us that we're more valuable when we're dead, and we're being bankrupted on our way there. Thank you.
Hey, good afternoon, everyone. I'm Ann Cassidy with the National Community Pharmacists Association. We represent the independent community pharmacists throughout the United States. So sort of what you think of the mom and pop pharmacies that I know a lot of y'all are familiar with. And I know, we've heard from a lot of different panelists today. We've heard a lot of facts and figures. And sort of 2 things that I'd like y'all to take away from this is, and this doesn't happen a lot, just think of the diversity of this panel and the impacts that the PBM practices are having across the whole supply chain, from patients to employers increasing cost for employees to physicians trying to prescribe the best, most cost-efficient prescriptions for their patients, and we're talking, diabetes patients, and then, for pharmacies. And interestingly enough, you just heard Chris with NACDS talk, that you think of the chain pharmacies, the bigger pharmacies, but we have a lot in common. He talked about all the pharmacies going out of business. In between June 2023 and June 2024, there was a net loss of, just independent pharmacies, of 450 independent pharmacies throughout the United States. So you can see the impact that PBM practices are having, just like I said, across the supply chain. And then number 2, we don't always get to, when there's good reforms that are out there that Congress can pass, we don't always get to tie that up with a savings bow. So we have a chart over here, and the PBM reform provisions that were originally included in the December CR amounted to about $5 billion in savings. And that's not a small amount of money, even by Washington, D.C. standards. So I think it's just really a common sense solution to this. It's not the silver bullet. It's not going to fix everything. But as Attorney General Yost earlier said, we've got to do something, and litigation is not going to fix everything. And I want to just really briefly talk about 2 of the policies that would be very helpful to independent pharmacies. We talked about delinking, we talked about transparency, and there's 2 issues. And the reason reimbursement reform and contract reform are so important is, now that PBMs are vertically integrated, so you have the insurance company that owns the PBMs or vice versa, and they also own pharmacies, mail orders, and then mail order pharmacies, and in some cases, retail pharmacies. So what does that mean? The entity that reimburses my members' pharmacies, they're our competitors too. So think about it like this. I think this is just an easy example. Imagine, so when they're contracting with independent pharmacies or even chain pharmacies, there's not a lot of negotiation there. So you have to think about, it's like Walmart deciding how much Target, this is exactly the same thing, Target can charge for their products, and what customers can even go to Target. So if you put that in sort of those simplified terms, it's just, to me, it's mind-blowing that that's allowed to take place. So really 2 simple policies right now that have overwhelming bipartisan support: getting rid of spread pricing and Medicaid managed care. Attorney General Yost talked about him doing an audit, and they found $235 million in Ohio. That's just one state. About 10 states have found that. So it gets rid of spread pricing by requiring a pass-through, paying pharmacies fairly, and limiting PBMs to administrative fee. And then the second policy that we're really pushing is requiring Part D contracts to be reasonable and relevant. And what that means right now is I sort of look at Part D as a wild, wild west in terms of contracting. PBMs send our members, and by the way, Part D is by far, we hear the most complaints about from our members, like just, it's not even close. And 55%, about 55% of independent pharmacies' business is Medicaid and Medicare, so you can see why this is a big problem. So right now, the contracts are take it or leave it. You've heard about DRR fees. Those have sort of been addressed, but it's still an issue. So all this legislation would do is, and there's really no cost to it, it would just require that CMS, number one, define what reasonable and relevant contract terms are, put some parameters around that, and then number two, enforce it. Pretty easy, common sense, and together, it saves over $2 billion, and then collectively, all these provisions save over $5 billion, or around $5 billion. So, we're very, very close, and there's not a lot of things in Washington right now, I think that Representative Auchincloss said that are bipartisan. This is bipartisan, it's bicameral, and there's overwhelming support. So, I just appreciate y'all coming here. I appreciate working with y'all, and if y'all have any questions, feel free to ask. So thank you so much.
Thank you, Ann. I'll give you guys a little unsolicited public speaking advice. Never agree to back cleanup after 9 speakers who cover everything and are awesome. We've heard now, though, from leaders in Congress, representatives of states, patient groups, rural communities, pharmacies, and independent pharmacists, and even forward-thinking PBMs who want to be part of the solution, as well as our friends from Blue Shield, California, a major insurance company, wanted to be here today to say that they agree, and they also want to be in this fight. I'd like to share with you just 2 minutes of the employer perspective. So ERIC's member companies voluntarily pay about 75% of healthcare costs for our workers and for their families, and sometimes for retirees as well. Our companies want to offer the best benefits possible at the lowest prices possible, but sometimes PBMs make this an impossible task. Think about what you want out of a successful drug benefit. For each medication, you want the PBM to negotiate the best price possible. You want them to offer the lowest cost product that is available. And you want that not just for the drugs that you personally take, but for everybody on the plan, right? Because the cost of everybody else on the plan affects the premiums that you have to pay every month. But at the same time, you want access to the drugs that you actually need. So you don't want heavy-handed tactics that make it impossible to fill the prescriptions that your doctor gives to you. What you've got to understand is that under the current system, what I just described will never happen. Never. As long as the PBMs can keep the rebates and the fees that they get from drug companies, they will always choose the drugs with bigger rebates, period, not the lowest cost drugs. And as long as they can keep the rebates and the prices secret, your employer has no idea and no way to crack down on their bad behavior. The big PBMs have created a number of fake employer groups. They've paid for a number of misleading push polls and economic papers, and they created a paid army of social media influencers to try to convince Congress that the grassroots and employers like paying high prices. We love wasting money on drugs. But you guys can see right through that. If you actually talk to employers in your district, they understand the scope of the problem, and they're frustrated because our hands are tied. One study found that 3 in 5 employers think that their PBM contract is problematic, complicated, and often benefits the PBM at the expense of the employer and the patients. 63% of employers said PBMs are not transparent about how they make money. We know that PBMs generate profits when a drug's price is higher. When the quality affordable biosimilar substitutes for the expensive drug Humira came out, one of the big PBMs actually made patients first try the branded drug. And they could only get the cheaper biosimilar if they could attest that the branded drug didn't work. So the biosimilar that FDA said was a safe and effective substitute for that branded drug, then they could try it. This is insane. If you think about this, this literally says you have to try the one that definitely is going to cost more for an equivalent before you can try an equivalent. This is just crazy. This kind of trickery should be illegal. And the solution is for Congress to take away the ability of PBMs to play both sides. They should either get paid by the employer or by the drug company, not by both. And you can accomplish this by enacting rebate pass-through and delinking PBM profits from drug prices, policies that, again, have already been agreed to by Democrats and Republicans in the House and in the Senate. If Congress does enact this legislation, I can promise you employers will lower drug prices. We will lower the drug costs that our workers and their families pay. It's that simple. If you give us the tool, we will do that. Will it completely solve the drug pricing issue? No, I'm sorry. Unfortunately, it is not a silver bullet. But you can make a massive difference. And the work in Congress is already done. It's already written, it's already scored, it's already got TA, it's already got an agreement. I'd like to thank each of you for attending the briefing today and for considering our ask to enact the PBM legislation that Congress already negotiated on the coming March funding package. All of our speakers have agreed to stick around for a little while if you want to talk to them or ask questions. I also want to thank our speakers and our special guests, including Chairman Comer, Representatives Dingell and Auchincloss. I know Chairman Carter didn't want to miss this event, but he's a little bit busy at the moment. We're confident that Congress can get these reforms across the finish line in the coming weeks, and you can contribute to getting this done. The time to act is now. Don't let that CR get through without finishing the job on PBM reform. So thank you. Have a wonderful day.